This chapter is very ambitious. It's got 47 abstracts, so I'm not going to attempt to hit all of them, I promise. It would be pushing me to the maximum of my fast talking, which I'm already, have a problem with. So I'm going to focus on the really common stuff, the information that you can really use, I think most of the time, more frequently than some of the other conditions. And so certainly in ophthalmology, there are very few true emergencies, all right? There's retrobulbar hematoma, where you might have to do a lateral kynthotomy. There's acute angle closure glaucoma. There's ruptured globe when you might have a viable eye, but those are pretty rare cases, but we see a lot of common ophthalmology type stuff. Now, in 2007, in terms of your eye exam and ophthalmology care, there should really be 3 widgets and gadgets that you're pretty familiar with. One is certainly the slit lamp. Knowing a little bit about a slit lamp is important. Using a tono pen for the intraocular pressure is a really easy way to measure and pretty reproducible. And how many of you have the panoptic scope from Welch Allyn? Anyone have the panoptic scope for fundoscopy? Thumbs up? Like it? Yeah. It's a really good tool. We use it a lot in the residency. It gives you a chance to get an actual fundoscopic exam. It gives you a fighting chance. It's a little widget and gadget. It's not that expensive. It's under $1,000. It's several $100s that allows you to bring the scope right up to the patient's eye, and it supposedly gives you 5 times the view of the back of the eye. You get a chance to really look at the retina, and it's a nice tool once you start to practice with it and learn it. It works quite well, and I think that's something that's actually a pretty decent development. Now, the first group of papers here talks about conjunctivitis, something that we see a lot. And the fact of the matter is, most patients that end up with a diagnosis of conjunctivitis, we end up giving antibiotics to a lot of them. But how do you decide in your mind whether this is a true bacterial conjunctivitis or a viral conjunctivitis or an allergic conjunctivitis? What kind of criteria do you use in your mind to differentiate between who you're going to give antibiotics to or not? Or do you not really use criteria and just give antibiotics to everybody thinking it's hard to tell the difference? What does the evidence say about can we tell the difference between these different types of conjunctivitis? And these are the papers that we're going to look at first. So the first paper is from the BMJ, and it's about predicting bacterial cause of conjunctivitis based on the signs and symptoms. And it's a Dutch study. They look at 177 adults with diagnosis of acute simple conjunctivitis. These are not immunocompromised people. They're not people who've had contact lenses in, which can muddy the waters, and no trauma, no recent antibiotics. So patients that present with a red eye, some kind of mucopurulent discharge, maybe an eye stuck together, that are going to get a diagnosis of conjunctivitis. And they did history and physical, and they cultured all these eyes to see exactly what percentage actually grow out bacterial culture. The prevalence of a positive bacterial culture in their group here was 32%. So a third of them with those symptoms had a bacteria grow out. And the most common bacteria that they got in this study was strep pneumonia in their case study here. In looking at the signs and symptoms, the only things that were really predictive of those positive cultures of those 30% were, the most predictive was 2 eyes glued shut in the morning. Both eyes glued shut gave you 5 points, very strong predictor. 1 eye glued shut, not so bad. That's another pretty good one. The things that went against it were you've had conjunctivitis before, it's kind of a recurrent thing for you, probably not bacterial, and if you have a lot of itching associated, also went against the bacterial culture being positive. And those are the things that they kind of teased out. Actually, the mucopurulent discharge in this study, they didn't find that to be actually as predictive as the eyes glued shut as a symptom. Now that needs to be validated in terms of what they found, but that's out of 177 people, this is kind of the findings of that study. Now, number 2 asks a very similar question. It's about extensive lab studies in acute conjunctivitis, and this looked at 700 patients that presented with a diagnosis in the end of acute conjunctivitis to the eye clinic at Bellevue, and all the cases got bacterial cultures, they all got fungal cultures, and if it had purulence, they did a gram stain, and if it sounded like viral, they sent it for viral culture, and for some people they did some lab studies. They did a lot of tests on these 700 patients with conjunctivitis, and from all of these studies, doing everything that you can imagine on these different ones, 84% of them, they were able to get a definitive diagnosis. Even having done all those studies, there's still a group that you can't say what it was. Nothing really came out of it. Now, the bacterial and viral infections had about a similar incidence. 38% turned out to be bacterial culture positive, and 35% turned out to be viral culture positive. The fungal, allergic, chlamydial, herpetic, all much, much lower in terms of how frequently they were seen. Now, this is an eye clinic at Bellevue, so we've got a little bit of a referral population bias here in this study. Keep that in mind. Again, undetermined, and 16% never got a definitive diagnosis of exactly what caused it. In this study, the bacteria that was most frequently cultured was Staph aureus. And they came up with a bunch of characteristics, clinical characteristics, that they thought could help you determine between viral, bacterial, and allergic types of conjunctivitis. For the viral conjunctivitis, which is a lot of the red eye, typical red eye that you see is actually viral conjunctivitis. Follicles under the lids, under the inferior lids, little follicles there. Not much in the way of discharge, more of a scant, watery discharge. And pre-auricular lymphadenopathy. They found that to be pretty positive in the ones that turned out to be viral culture positive. And that's probably not something that we do on every eye exam when we look at conjunctivitis, is actually palpate for nodes. Maybe it's something we should do, is to actually feel and see if there's lymphadenopathy there. For bacterial, they found that mucopurulent discharge was a predictive factor in their study for bacterial culture being positive, and they didn't have any follicles or any adenopathy in the bacterial cases. For allergic type of conjunctivitis, they found that chemosis, having a significant amount of really kind of swelling there, is indicative of an allergic type of conjunctivitis. The finding of cobblestoning when you look at the conjunctiva is another clinical thing. And the discharge tended to be more stringy or mucoid in their description from the Bellevue Eye Clinic here. In 76% of the cases, so most of the cases, the clinical diagnosis by the ophthalmologist correlated with what the lab findings were. So by these clinical criteria, they kind of did a pretty good job at predicting what the actual results were going to be by all these lab studies. There's one paper that's not listed here in the database but came out a couple months ago about pediatric conjunctivitis. It was in academic emergency medicine by a guy named Patel from the DuPont Hospital at Brown. And they swabbed 111 kids' eyes. This is a pediatric study of conjunctivitis in kids. Again, final diagnosis was conjunctivitis, do the bacterial culture, how many of those were positive. And in this study it was 78%, so a lot higher actually than the previous studies that were mostly adults. Most of the culture positives in these pediatric patients were non-typable H. flu, so even a third organism being thrown out there as a possible common cause of bacterial conjunctivitis. But they agreed in this paper that the eyes glued shut was a very predictive feature of the bacterial culture ending up being positive. And they also felt that a mucopurulent discharge did also predict that the culture was going to be positive. So the next topic is, if you decide to give an antibiotic, what is the evidence that antibiotics make any difference in conjunctivitis? Do they actually matter? Do people get better a lot faster? Does it prevent some terrible complication? What do the papers actually say about this? Which a lot of us give antibiotics to these conjunctivitis cases, so are we doing them much in the way of good? And number 3 through 5 look at this. Number 3 is a Cochrane systematic review that these Cochrane papers combine a bunch of studies, kind of a meta-analysis type of thing, and give a sort of final recommendation. Review of topical antibiotics and acute bacterial conjunctivitis. And in fact, Cochrane actually had published a systematic review in 2001, and at that time there were really only 3 studies that they pulled together and made any recommendations on. And then a couple more studies came out after 2001, so in 2005 they published again, so that they had the 5 studies that they pulled together to make recommendations. There were 2 major studies that happened between 2001 2005. One of them is number 4, which we're going to look at as well as an individual study. But the total in all these 5 studies were just over 1,000 patients, adults and kids, so a mixed bag of types of patients being pulled together. But the summary was that the relative rate of clinical remission with the antibiotics was 1.24 at the 2 to 5 day interval. So at an early outcome, you were just likely to get a little bit better than you would have been, being that 1 would be like a neutral, like nothing really mattered. So just barely got a little better faster, versus 6 to 10 days it was 1.11. So that the suggestion was that if it does any good at all, it's at the very early stage at the 2 to 5 day interval. By 6 to 10 days, not much in the way of impact of outcome. Effect seemed to be marginal. And to fully illustrate the same point, let's look at number 4, which says it a little bit better, I think. Lancet 2005 so big paper, chloramphenicol drops for acute infective conjunctivitis in pediatric population. Actually a double-blind controlled British study where they randomized kids to placebo drops or antibiotic drops. So I think this is a nicely designed study. They looked at 326 immunocompetent kids, 6 months to 12 years old, with a diagnosis of infective conjunctivitis, and you either got placebo drops, you got nothing, or you got chloramphenicol drops. And they cultured all the eyes as well. And they found that in this group of pediatric patients, again, 78% were bacterial culture positive. Same exact number as that other study from Academic Emergency Medicine. 78% bacterial culture positive, 13% were viral culture positive in these kids. And again, the most frequent organism they saw here was H. flu. Now, by day 7, how were the kids doing? Who got cured? In the placebo group, 79% of those kids were better. And of the antibiotic group, the chloramphenicol group, it was 86% were better. So almost the same, 79% placebo, 86% chloramphenicol. Actually not much in the way of statistical difference there. The chloramphenicol, the antibiotic drop group, were better, how much faster? They were better 0.3 days faster. So it wasn't even a full day, it was like a third of a day they got better faster. And in fact, I'll tell you what the conclusion was of this British paper. They came up with a conclusion, which was that, you know what? Parents shouldn't bring kids with red eyes to the doctor because the antibiotics don't matter. So they shouldn't even go to the doctor. In fact, they said, you know what? Unless the red eye persists in more than a week, don't bring kids to the doctor that have red eyes because it doesn't matter what we do for them. Which is kind of the American conclusion would never be that. But from the British point of view, with their healthcare system, that was their conclusion. We just shouldn't be using the doctor in this way. Number 5 agrees with the Cochrane review. Again, some advantage for antibiotics at an early point, the 2 to 5 day point, very minimal advantage, but by the week or so, the advantage seems to fall off. Now, there are a lot of different topical antibiotics that we have to choose from, and what are the recommendations for what we should really choose? And the fact is, since we just said that probably they don't make much in the way of a difference, probably what you choose doesn't make as much of a difference as you might think it does. So certainly choosing something cheap is very important, I would say. But number 6 through 11 all look at this, different ointments and drops and some recommendations here. Number 6 is a review of antibiotic therapy for ocular infections. And they point out one important thing, which is that there is an ocular infection that you don't want to treat with topical drops or ointments at all, which is gonorrhea of the eye. It needs parenteral therapy. It needs parenteral antibiotics. And this should be in kind of a different category. It's actually more of an endophthalmitis. It's a very hyperacute, very nasty looking conjunctivitis with a lot of chemosis. I mean, discharge pouring out of the eye. It's usually an auto-inoculation of a genital type of gonorrhea infection that they touch the eye, and then that's how the gonorrhea gets there. But if you see a really bad conjunctivitis like that, you want to consider it, and you want to consider giving them a dose of ceftriaxone or some other parenteral agent that's active against gonorrhea. And you might want to culture those to rule this out as a cause. Number 7, conjunctivitis in children. This paper is from 1979, a while back. And in this paper, they actually, without a lot of the later papers that we've talked about that showed that if you culture conjunctivitis in kids, that bacterial is a pretty common cause, the assumption here was that actually probably viral, red eye, pink eye is really more common in kids. And because that's true, be careful about throwing too many antibiotics at the kids because they probably are mostly viral, and we don't want to avoid unnecessary antibiotics here. And they thought that if you think that you have a viral conjunctivitis, what you should do is just recommend that the parents clear out the secretions and little compresses, and it's going to get better on its own. And that they recommended if you're going to use something, sulfacetamide drops during the day and the ointment at night. And we'll talk a little bit about that drug in particular, and also about ointments versus drops. Number 8 is looking at viral conjunctivitis and giving topical NSAID drops, the ketorolac drops. And this is a randomized double-blind pharmaceutical-supported study, which is interesting because it actually has a pretty negative result. But 105 patients that were being presumptively diagnosed with viral conjunctivitis, and the presumptive diagnosis was based on the clinical features, a lot of which we've talked about. Follicles in the lower lid, a little bit of preauricular lymphadenopathy, maybe a pre-existing URI, recent contact with someone who had a red eye, so kind of the infective pink eye type of situation, and they randomized them to either got artificial tears for your discomfort or you got the ketorolac drops for your discomfort. And they found that there was really no advantage to either one. In fact, the artificial tear group did a little better. The redness went away a little faster with the artificial tears, and the ketorolac group reported that they had a little more stinging than the artificial tears group did. So there was really no difference there, no advantage to using NSAID drops with viral conjunctivitis for the discomfort. Number 9 through 11 are all drug delivery papers that talk about ointments versus drops and the advantages and disadvantages. Number 9 is a therapeutic review, has a few points to take away. Ointments provide greater contact with the eye, and so therefore you can apply the ointments less frequently than you do need to give with the drops. Some people don't like the ointments because they're kind of goopy and that whole thing, but they do provide better drug delivery for the eye. Drops give you more systemic toxicity than the ointments do. They get absorbed through the nasolacrimal duct more than the ointments do in terms of delivery of drug. And in general, they say that ointments don't affect wound healing, but they caution that if you have somebody with a corneal laceration or a really deep wound, that probably ointments are not a great idea in those settings. They kind of say both things. Number 10 talks about improving the therapeutic index of your topically applied ocular drugs. And they make a good point, which is kind of what we call the 5-minute rule, which is if you're going to give somebody drops of something, whether it be timolol or some other agent, and you're concerned about the absorption of that drug, there are some things that you can do to have to decrease the amount of absorption that that drug will have. And so one thing you can do is to actually compress the nasolacrimal duct for 5 minutes after you use the drops. And this actually not only decreases the systemic absorption, but it increases the amount of absorption into the anterior chamber of the eye as well. The other option is to just close your eyes for 5 minutes, and that also has been seen to have a decrease in the amount of absorption, systemic absorption of the drug, of the ocular drug as well. So that's an important thing to remember, that if you squeeze here, you're not going to get as much systemic absorption. We'll talk about a little bit of the bad things that can happen if you absorb some of these drugs. Number 11 is about sulfacetamide, probably one of the more common ophthalmologic topical agents that are used. And they talk again, like we said, about the fact that if you use the drops, you have to use them pretty frequently. They come in different concentrations. So the more concentrated the sulfacetamide solution is in the drop, so like a 30%, you can use that less frequently than the 15%, but the more concentrated it is, the more reactions you get to it, so the more irritation patients may potentially feel. So they recommended, the drops during the day also, and some ointment at night to increase the drug delivery at that time. If you really want to give antibiotics, that's how to max it out. So what kind of potential systemic effects can you get from eye drops? And number 12 through 14 look at this, and they talk about some specific examples of drugs. And number 12 points out that phenylephrine drops have been shown to be associated with cases of MI, of hypertensive emergencies, of subarachnoid hemorrhage. Pilocarpine drops can give GI symptoms, sweating, salivation. But the most important one is probably timolol, which is a beta blocker. And it can have systemic beta blocker effects, and it could tip you over into heart failure or have a systemic bradycardia. Hypotension, syncope, all of these have been related to timolol as a drug being absorbed once it was given as an eye drop. And it reminds us just to ask about eye drops on the list of medications. Often people don't say what their eye drops are. They don't think of that as one of their prescription bottles because it's sitting in the fridge or whatever. So it's something to ask about, especially in older folks who might be on glaucoma drops. It might be the explanation for the syncope that you're seeing or the bradycardia that you're seeing. It might be something that might be causing those things. And number 13 looks specifically also at timolol. And they look at the reported adverse events to the FDA about timolol over a very long period of time, 1978 to 1985. And there were over 3,000 serious adverse events reported to the FDA about timolol during that period of time. There were 450 serious respiratory and cardiovascular events and 32 deaths in that period of time that were related to timolol, or thought to be related to timolol. Now, half the time, certainly, it was cardiac arrhythmias and bronchospasm, and most of those patients, especially the ones that died, had pre-existing cardiovascular and respiratory disease. So we know who's at risk for having side effects from this drug. We just have to be careful about telling them about that this is a beta blocker and you can absorb it, and you should use this little trick and that kind of thing. So we know who's at risk, and we should be a little careful about these kind of things. Certainly that's best information for the ophthalmologist who's prescribing it. We're not frequently prescribing that drug, but it might be something you might touch on with your older patients. Now, number 14 talks about anticholinergic drops, which are commonly used to dilate the eye in an ophthalmologist's office. And these can also be absorbed, and they can have effects. And this is particularly true in elderly patients. Old anticholinergic drugs can be a cause of altered mental status in elderly patients, and it might not be something that you've thought of if they've just been to the ophthalmologist's office. It can happen in children, too. It can make them act a little weird. Now, they say in this paper that, how would you know that it was the anticholinergic drop that caused the altered mental status, not urosepsis and that kind of thing, assuming that your workup is negative. They say if you give physostigmine and it reverses it, then you would know that it was the anticholinergic effect. And I think, we all hear that. We go, physostigmine, that's not a drug that we use very commonly because it has its own set of bad effects with it as well. But just theoretically, that's what you would do if you wanted to prove your point. Now, the next little section looks at anisocoria, different sized pupils, people coming in saying my pupil's bigger than the other, and I've heard that's related to an aneurysm, and that's what's happening to me. And talks about some of the benign causes that can be explanations for the enlarged pupil. Now, certainly we know that people have individual differences. There's a certain percent of our population that has one pupil slightly larger than another. And we do worry about the third nerve and aneurysms pressing on the third nerve, causing the dilated pupil. But there are a few other non-scary things that can cause this too. Number 15 talks about scopolamine patches, and a couple cases of scopolamine patches causing this. People touching the back of their ear where the patch was and then touching their eye, and the eye dilates, and then they notice it and they get scared. This is kind of a case report of a couple patients that this was attributed to the scopolamine patches. And you can diagnose this by the failure of the pupil to constrict if you use pilocarpine. If it won't go down, then it's a pharmacologic block of the nerve there. There's some plants that can do that too. We had a case of somebody who was working in their garden, was touching either nightshade or something like that, then rubs the eye and then it gets dilated. So there are some botanical causes as well, say. Number 16 looks at anisocoria and the aerosolized anticholinergics that we use for COPD and asthma, like ipratropium or aerosolized atropine. And this also can cause an eye to dilate, and this is another cause. And in fact, it brings us to 17 and 18, which say that if you have this happen, you can theoretically precipitate acute angle closure glaucoma in the same kind of mechanism that we learned that you walk out of the dark theater and in the dark theater your eye is dilated, and that's what precipitates the glaucoma. If you were to have this kind of pharmacologic thing happen in the right sort of patient, it's a setup for acute angle closure glaucoma, and they report of a couple cases where this happened. Number 17 was 2 cases of patients with COPD who got aerosolized atropine and had this happen, and number 18 is the same thing. So what are the recommendations? How do you avoid that? Is this really a concern? Well, certainly if you're going to use a face mask and you're going to use this drug, you want to make sure that the mask fits. You want to try not to get the medication in the eyes, especially in older patients that might be at risk for this. They make the recommendations in these papers that you should ask everybody about whether they have glaucoma symptoms. Do they see halos? Have they ever been diagnosed with that before? And I think that's a little overboard. But certainly, using a handheld nebulizer and making sure it doesn't, trying to avoid it going in the eye is a good thing. If you are really worried about it, you could use an MDI with a spacer rather than an automatic drug delivery type of thing. One of the papers actually says you should put eye protective devices on all these patients that are getting the spray, which is like, okay, that's a little out there. But that's the kind of thing you want to think about, that these drugs that are being aerosolized can have effects when they're absorbed other places. The next little group of papers is really interesting, number 19 and 20, and they talk about the relationship of intraocular pressure to intracranial pressure. This is kind of a new concept. Now, how would this relate? If you have intracranial pressure elevated, how does that raise your intraocular pressure? Well, the thought is that if your intracranial pressure is up, this puts pressure on the venous system, and the venous system, the cavernous sinus system then backs up into the ophthalmic vein system, which backs up into your episcleral veins, and it raises your intraocular pressure. So there's been a couple little studies looking at this, and there's a very clear relationship between these two things. Number 19 is a paper from Annals from May 2004, and it's actually one of the most frequently referenced papers in Annals that's out there. And they looked at, it's a small little study, very smart, 27 ICU patients that all have ICP monitors in. So they know what the ICP pressure is. And then they take the tonal pen and they do their intraocular pressure. And it just is a very, very clear relationship. When the ICP is high, the intraocular pressure is high. It's fascinating. These patients had no known glaucoma, so those were excluded. Their ICP monitors were in for different reasons, mostly intracranial hemorrhages, whether whether it was strokes, trauma, could be some shunt malformation, those kind of patients, all in this study. They did 76 different intraocular pressure measurements at different times, correlating it with the ICP. And they just went linearly up like this: sensitivity, specificity, 100%. I mean, if the ICP was high, the intraocular pressure was high. They just went right together. And if it was normal, it was normal. And it's a really interesting kind of thought that could we start using this as a screening tool. And I don't think this study suggests that it's safe to do that yet in any undifferentiated ED patient, but it's an interesting relationship to look at. And number 20 looks at the same thing. It's from the Annals of Neurology in May 2006, and it's an Iranian study. And they had 50 patients with a wide variety of diagnoses who got lumbar punctures and had very high opening pressures, were proven to have increased intracranial pressure. And they measured their intraocular pressure by the Schiot's method, not the tono pen. But they also found a very clear linear relationship between the two things. So there's really only 2 studies out there, but I can tell you that there's other studies going on, that's for sure, to look at other patient populations in the ED and whether this could be a tool that you could use to predict what somebody's intracranial pressure would be, a very quick way. The next interesting question is about, do refractive errors actually cause headache? It's frequently a thing that we kind of come to, well, maybe you need glasses, or someone thinks I must need glasses because I'm getting headaches, and are these two things really related? What's the evidence here? And number 22 is a paper that asks, is this really myth or is it reality? And it was in the Journal of Headache. And they took 105 patients who had an uncorrected refractive error, and they asked them a bunch of questions about their headaches, like how frequently do you get them, what do they like, blah, blah, blah. And they took a control group of 71 patients who were corrected. They had glasses or they had no refractive errors, and they compared what the headaches were like in these 2 different groups. Were they more frequent in the refractive group? Were they different? And in fact, the groups were about the same. Of the patients with refractive error, about 45% of them had headaches, and 51% of the control group did. So no more frequent incidence of headaches. But there were 7 patients in the study group, which is about 6%, that actually fulfilled the Headache Society criteria for headache of refractive error. There actually is a set of criteria that you can use to put people in different boxes in terms of what kind of headache they have. And if you have a headache that's from refractive error, it has some particular characteristics. It should be a mild headache. It should be in the frontal area around the eyes. It shouldn't be there when you wake up in the morning because you haven't been using your eyes. And it should be there when you're doing tasks, visual tasks that involve your refractive error. And that's how you can sort of really link the headache to the refractive error according to the International Headache Society. And they looked at this group, the study group that had the headaches with the refractive errors, and they asked them after the refractive errors were corrected, did your headaches get better and less frequent? And in fact, about 3/4 of the group said that their headaches did get better after they got glasses. So there is a connection there. Maybe not as frequent as we attribute it to, but there is a connection between refractive errors and headaches. Now, the next big section is about corneal abrasions and eye patches. And in fact, there's 9 papers here, number 24 to 31, all talking about this. This is a common thing we see, corneal abrasions. And the bottom line of these 9 papers is that there's really no advantage to using eye patches with corneal abrasions. They all say the same thing, looking at adult populations, pediatric populations. These eye patches don't help these abrasions heal faster. Patients aren't very compliant with them. It's really unnecessary, and they're uncomfortable, as we talked about. And then I'm going to finish there. I think I'm about out of time. Just to mention what's left here for you to look over is a little bit more about corneal abrasions, and then there's a bit about hyphema and admitting patients with hyphema or not. And then the last part is about flushing eyes out. What kind of solution should you use? And lactated ringers is a little better than normal saline, just to give you the punchline on that one. Yes?
Yeah, I'm unclear about your drops versus your ointment.
Yes. Yes. There's no advantage to one over the other. The ointments you have to use less frequently. In terms of that comment about wound healing and whether it might affect it healing, I think the bottom line is with most abrasions that we see, which are not serious wounds, they're very superficial and small, you can use either one. You can use either one. They were talking more about like when you have corneal lacerations or big kind of wounds, that ointments theoretically there may not be such a good idea, even though they say that they don't affect wound healing. But certainly with the most common, all the abrasions that we see, those are really minor superficial things, and you can really use either one. Either one. And I think you just have to kind of talk to patients about which one would you prefer. You don't have to use the ointment as frequently, or would you rather use drops? I mean, people have some feelings about that. But ointments are, they're nice because you don't have to use them as often. But then again, you have the goop in your eye. Yes?
Contact lenses user?
Yeah, so contact lens users are at particular risk certainly for ulcerations. They definitely need the fluorescein to look and see if there's anything besides just a conjunctivitis there. But they're at particular risk for Pseudomonas. That's the organism that's the worrisome thing with contact lenses. So in terms of treating them, they do need antibiotics when they have a problem. And they often need a referral to an ophthalmologist as well to follow up and make sure that it resolves because it can be more serious there. And fluoroquinolones are a good choice there as well. Other questions? Yeah?
How about eyelid swelling?
Eyelid swelling in the setting of?
You didn't see anything there. Just eyelid swelling, maybe mild redness.
On the upper lid?
Yeah.
Well, those can be blocked follicles, right? Eyelash follicles, and if they're mild, I don't think you need to do much for those. You can just do compresses. Some people, would make those equivalent to blocked hair follicles and like a dacrocystitis kind of thing, and they would use some antibiotics with those as well if it looks kind of bad. But you also want to differentiate that from a preorbital cellulitis. You want to make sure that that's not what you're talking about as well. If we're just talking about kind of a local thing, then it might be a follicle, but you want to make sure it's not a preorbital cellulitis, that it seems more general. Then it definitely might need more also oral antibiotics too. And we're done.